Good evening, all the aspirants present here. This is going to be our debriefing session, which will be taken by Dr. Asif Iqbal, sir. He is a HOD, Respiratory Critical Care and ECMO Services at Apollo Multi Speciality Hospital, Kolkata. I believe all the aspirants present here have given their mock examination. And if not, if someone have missed their examination, it's very much required for all the aspirants to kindly unmute your mics, or you can also give answers in the chat box, as it's going to be a very interactive session. Thank you, sir. So you can start.
Yeah. So, how many of you have given the mock exams? Please, you can raise your hand or you can write down in the chat box. I hope for the next week is the new year, and new year we will start our new LMS where you will have the performance result, your friends' performance and all over the student who are in the academy from different continent. You will judge yourself where you are and where your friend are. So without delay, we will start today. Uh, okay. The first question, with respect of intensive care management of acute liver failure, evaluate the following statement. The statement is acute liver failures is typically associated with low output circulatory state, frequent mandatory vasopressor therapy, extensive hepatocellular injury in ALF commonly lead to hyperglycemia. It is a true-false kind of question. Application of high level of positive end expiratory pressure can worsen the hepatic venous congestion. Invasive cranial pressure monitoring is recommended. Patient with mild grade 1, grade 2 hepatic encephalopathy and N-acetylcysteine has demonstrated benefit selected patient with non-paracetamol related acute liver failure. So please put your answer in the chat box. Can you please give your answer? You can try at least, yes. Abrar Ibrahim, yes. Anyone? Abrar has tried. So acute liver failure typically associated low output or high output. What Abrar said? False, yes. Then next one, extensive hepatocellular AF commonly lead to hyperglycemia or hypoglycemia. It's actually hypoglycemia, so it's a false. Then application of high level positive N-expiratory pressure PEEP can worsen hepatic venous congestion. Some of say false, some of say true. Hepatic congestion is true. I will explain one by one. And invasive cranial pressure monitoring recommended patient mild, not mild, it is a advance. Then N-acetylcysteine demonstrate benefit patient with a non-paracetamol related acute liver failure is true. Just a minute. Explanation is acute liver failure characterized by hyperdynamic circulation state with high cardiac output, low systemic vascular resistance. So, low systemic vascular resistance, hypotension, often increasing vasopressor support despite adequate volume resuscitation, increased nitric oxide mediated vasodilation play the central role. Then your second statement was hepatocellular injury cause hyperglycemia. No, Hepatocellular injury is caused the hypoglycemia. Why? Because it reduces the glycogen store and the impair neoglycogenesis. That's why there is a hypoglycemia. Third one is your application of high P positive and expiratory pressure can worsen hepatic venous congestion. Yes. Why? Because it reduces the venous return and therefore it increases the venous congestion in the hepatic area. Then invasive intracranial pressure falls. Why? Because it is recommended for severe acute liver failure. Grade 3 and grade 4 where the brain edema is happen and in acetylcysteine is it improve transplant-free survival in non-paracetamol poisoning, especially administration called Grade 1, Grade 2 hepatic failure. So now coming to a discussion, what is acute liver failure? Acute liver failure is defined rapid onset of severe liver dysfunction. There is a criteria. One is coagulopathy. The INR should be more than 1.5, hepatic encephalopathy, and occurring within 26 weeks of uh, your acute liver disease. Jaundice to encephalopathy, it should be less than 26 weeks and no pre-existing liver disease. And it can be divided into mild, moderate, and acute, hyperacute. It is depend upon the if the symptom and encephalopathy, jaundice and encephalopathy is less than 7 days, is a hyperacute. Within 3 weeks, it is a acute. And what are the commonest cause of acute liver failure? If it is the question in the EDIC, then commonest cause is paracetamol poisoning. If mentioned non-Western country or Asian country, then it is a viral hepatitis is the major cause. And other also autoimmune hepatitis, toxin, pregnancy-induced acute liver failure. And I've already mentioned hyperacute is less than 7 days, acute 7 to 28 days, and subacute more than 28 days to 12 weeks. And what about the hemodynamics? Hemodynamics is hyperdynamic circulation, high cardiac output, low systemic vascular resistance, and vasodilatory shock and vasopressin noradrenaline is preferred drug. And what are the other metabolic drainagement in acute liver failure? One is hypoglycemia, other is lactic acidosis, hyponatremia, hypophosphatemia, and hyperammonemia. And pathophysiology, how hepatic encephalopathy happen when there is a hepatic failure. Ammonia detoxification is not done in the liver, then plasma ammonia increase. This plasma ammonia is astrocyte swelling due to glutamine accumulation in the brain cell, cerebral edema, increase ICP, loss of cerebral autoregulation. And when you will do the ICP monitoring, usually grade 3, grade 4 hepatic encephalopathy or persistent listed uh, usually it is said grade 3 grade 4 and on and there is a risk of bleeding. Outline measure to prevent cerebral edema. How will you prevent? It is the same as in the traumatic brain injury, head up 30 degree, avoid hypercapnia, hypoxia, maintain serum sodium in between 145 to 155. That's why again you will get question uh, on different type of fluid. So never use lactate or ringer lactate or balanced salt solution where sodium content is less, because hypotonic solution is causing the brain edema. It increases the brain edema. You can use mannitol to maintain ICP or hypertonic saline and avoid prophylactic hyperventilation. N-acetylcysteine has a good role. It is indicated or antidote for paracetamol-induced acute liver failure, beneficial in non-paracetamol acute liver failure, and
Kayak kami kalau acara, ada juga acara India.
uh,
Yang orang itu udah jantungnya maju
sana,
juga ini.
sana, yeah. Then improve transplant-free survival and renal dysfunction in acute renal failure. Renal dysfunction is common. AKI happen 90%, 50% cases. Just a minute. Hello. High chance of AKI due to two mechanisms. One is ATN, sepsis hypotension cause ATN, or hepatorenal physiology. Then CRRT, if the renal replacement therapy is needed, preferable is CRRT. And regarding the infection point of view, the bacterial infection, fungal infection is a high chance. And prognosticate criteria, there is a King's College criteria, or there is a MELD score. This two score will give you about the survival benefit. And King's College criteria for liver transplantation, where persistent atrial pH less than 7.3 and INR if more than 6, creatinine is more than 300 micromole per liter, or grade 3 for encephalopathy, then there is you have to go for transplant. Indication for urgent liver transplant, one is the fulminant fulminant hepatic failure with King's College criteria more than 2 positive, progressive encephalopathy, persistent coagulopathy, and rising lactate despite of resuscitation. Mechanical ventilation is needed in a hepatic failure patient to protect airway, control PO2, PSCO2, and facilitate ICP management and the reduced metabolic demand. That's all about the hepatic failure. And the management of hepatic failure is the supportive management. You have to manage the hemodynamic resuscitation, and then management of ICP, and management of ammonia by giving the bowel wash and Dupalac bowel wash, lact lactulose bowel wash, and also if it is a paracetamol poisoning, then N-acetylcysteine, and also non-paracetamol poisoning cases, you can use um, N-acetylcysteine, and more of a supportive care and regular watch on the coagulopathy, and you have to send coagulation profile and correction of the factor. And second important thing is that you have to do regular basis take. Okay, next come to the next question. Acha, regarding the pathophysiology management of acute visceral hemorrhage, and assess following statement. The immediate mortality associated episode of acute variceal bleeding approximately 2%. Portal hypertension is the principal mechanism of responsible for the development of the variceal bleeding. Terlipressin is effective in reducing ongoing visceral hemorrhage by decreasing splanchnic blood flow. Empirical broad-spectrum antibiotic therapy should be initiated early during an episode of acute visceral bleeding. In a refractory and severe cases, transjugular intrahepatic photosystemic shunt liver transplant should be considered. Please give your answer first. Write down question number, then you give your answer. Please write down the question number, then give your answer. Oh, okay. Hilal has tried. Mustafa has tried. My request, everyone please participate. So everybody has tried. Okay. Upper GI bleeding, one of the catchy area where you will get question. Definitely you will get question. So GI is one of the area where you can get good scoring. So the answer, the first one is false. The immediate mortality associated with episode of acute visceral bleeding is approximately 2%. No. Is despite advanced endoscopic, pharmacological, and critical care management, variceal bleeding carries early mortality approximately 8% and 6-week mortality approaching 15 to 20%, particularly in patients with advanced cirrhosis. Then portal hypertension is a principal mechanism responsible for development of variceal bleeding. Portal hypertension. The variceal bleeding from portal hypertension, not, oh, sorry, this is the twist of the question is hypotension, portal hypotension. Actually, portal hypertension is cause for the bleeding, and clinical significance, portal hypertension occur when the hepatic venous pressure exceed 10 mmHg, leading to diversion of the blood flow and formation fragile post-systemic protosystemic circulation. Then third option, terlipressin effective reduce ongoing. That is a recommended terlipressin. Then your empirical broad spectrum antibiotic therapy should be initiated early during episode of acute visceral bleeding. Early administration broad spectrum antibiotic, it reduces the infection rate, rebleeding, mortality, and considers standard care irrespective of overt sepsis. Then, in refractory severe cases, transjugular hepatic photosystemic shunt tips, liver transplant should be considered. Option is yes. In a uncontrolled and recurrent variceal bleeding, despite optimal medical endoscopic therapy, the TRIPS is the bridge for, bridge for transplantation, and your bridge for transplantation and liver transplantation is the definitive treatment. Now coming to in the topic an upper GI bleeding. What is upper GI bleeding? Upper GI bleeding is defined as if the bleeding started from above the ligament of teres, then it is called upper GI bleeding. And clinical presentation, which most specific upper GI bleeding. Actually, the upper GI bleeding, the commonest cause, if you go, the peptic ulcer is the commonest cause, and the peptic ulcer, duodenal ulcer is the more common than the gastric ulcer. And the majority of the upper GI bleeding is due to non-variceal bleeding. It is due to trace ulcer or the ulcer. And variceal bleeding, esophageal varices is the more common than the gastric varices. Then portal hypertensive gastropathy is the another cause, contributing factor. Mallory-Weiss syndrome, gastritis, duodenite. Lower gastrointestinal bleeding due to diverticulum, colonic polyp, inflammatory bowel disease, hemorrhoid, anal fissure. These are the thing. So whenever you will get this type of question, you might ask about the resuscitation. The resuscitation is goal is to high permissive hypotension. That is called permissive hypotension. The blood pressure, systolic blood pressure should be 9, above the 90, not more than 140, to reduce the risk of rebleeding. And your the risk factor for the rebleeding, one is the aged patient. If there is a endoscopically there is a sputter is there, or the patient having ascites or CLD. These are the high risk group where you might get there is a chance of rebleeding. And commonest cause I have explained. The initial priority management is to resuscitate the patient and then put the your uh, airway protection is the initial priority, and then volume resuscitation, blood transfusion, then intravenous proton pump or urgent endoscopy. So, and transfusion strategy, what will be your transfusion strategy? Targeted hemoglobin should be is more equal 7. And it has been shown that the restrictive blood transfusion has a better result than the liberate blood transfusion. Variceal bleeding, if there is a variceal bleeding, then the treatment is your octreotide or talipersin to reduce the splanchnic hypertension, and it causes splanchnic vasoconstriction to reduce splanchnic venous pressure, and then endoscopically you can go for clipping. Antibiotic role, yes, antibiotic has a good role. It reduces the rebleeding. And risk scoring. The risk scoring is prognostic score is Glasgow Blathers-Ford score, and rebleeding score is the Rockall score, and pre-endoscopic Glasgow Blathers score is the your prognostic, and Rockall score is the endoscopic score. Endoscopic time. Remember, there is no hurry of the endoscopic immediately. Within 24 hours, you can do endoscopy. And when there is a stress-related ulcer, so when you will have the stress-related ulcer, your enteral feeding, you will continue enteral feeding. Okay. So question number 4, with respect of perioperative and postoperative consideration following esophageal resection, evaluate following statement. Use of lumbar epidural is expect to provide optimal postoperative analgesia. Fiber optic bronchoscopy should be readily available to verify correct position of double lumen endotracheal tube. Pulmonary complications are frequently following esophagectomy. Non-invasive ventilation in the early postoperative period strictly contraindicated. New onset rapid atrial fibrillation occurring between postoperative day 3 to 7 may be early indicator of an anastomotic leak. So please put up your answer. Give question number and give answer. This is question 4. So esophagectomy, thoracic epidural rather than the lumbar epidural provides superior analgesia by improving the pain control, cough effectiveness, and early mobilization should be considered unless contraindicated. So what was the option? Use of lumbar epidural. No, it is a thoracic epidural. Then fiber optic bronchoscopy should be readily available. True. So when you are putting the double lumen tube, those who are anesthetists, you will understand that always it is indicated to put the double lumen tube in the bronchoscopic guided. So it will give you the better placement of the tube. Otherwise, when you want to do one lung ventilation, if your tube is not placed, then it will be very difficult. Pulmonary complications are frequent following esophageectomy. It's not always, if unless there is a the respiratory complication common after esophageectomy approximately 20 to 30% patient, and this may necessitate critical care readmission, escalated respiratory support, reintubation, cardiovascular complication. Actually, if you see the complication of esophageectomy, the respiratory complication is more. Why? Because of if there is an anastomotic leak, then mediastinitis and cause the pulmonary complication. Non-invasive ventilation is not very contraindicated for esophagectomy patient, but it is said that it is better to avoid. Otherwise, if there is a anastomotic leak, it will create more problem. But now recent literature said NIV is now recommended post-operatively, and they have found that if the pressure, the inspiratory pressure of BiPAP NIV not more than 12, or the peak pressure not more than 6, then the complication is less significant. And Japanese classification system, what is this? It is okay. So new onset rapid atrial fibrillation occurring between postoperative day 3 and 7 may be early indicator for anastomotic leak. Yes. Why? Because it causes the mediastinitis, and mediastinitis causes increased irritability of the heart, and which produces the AF. So new onset AF in a post-op patient, especially in the mediastinal surgery, you will always think about the anastomotic leak. The question number 5. With regard classification system used in acute liver failure, evaluate following. The O-grade classification categorizes ALF into hyperacute, acute, and subacute form. The O-grade system ALF is labeled as acute when the interval between jaundice and encephalopathy less than 1 month. Okay. The term of hyperacute describe the ALF hepatic encephalopathy develop 1 week onset of jaundice. The Bernoulli classification divided into ALF into acute and subacute category, and Japanese classification separate. So you have to have this three classification: O grade classification, Japanese classification, and Bernoulli classification. Is more or less same. O grade O grade is King's College classification. Hyperacute less than 7 days. Then hyperacute less than 7 days. Acute is the less than 4 week and subacute 4 week to 12 week. And within the OGRI framework, ELF consider acute when encephalopathy started, and jaundice and encephalopathy duration is the 7 days. Acha, hyperacute when it is less than 7 days. And Bernoulli classification does not use term acute and subacute. Instead, ALF divided into fulminant, subfulminant, fulminant encephalopathy within 1 to 2 weeks of jaundice, and subfulminant encephalopathy occurring after 2 weeks. And last one, Japanese classification, fulminant type, subtype into acute 0 to 9 and subacute. It is just matter of the days. You just remember Magav, all these things, because there is O grade classification is more commonly used in India also. But for MCQ purpose, you have to remember all three classification. With respect of alcoholic liver disease, assess following statement. Approximately one-third of the patient with cirrhosis develop hepatorenal syndrome within first year following diagnosis. Single UKM unit alcohol contain approximately 20 to 24 gram of ethanol. Alcohol-related liver disease may be complicated by Wernicke's encephalopathy. Metabolism of ethanol promote lipid accumulation within the hepatocyte. Tumor necrosis factor inhibition with infliximab is effective in the preventing of hepatorenal syndrome with severe ALD. The hepatorenal syndrome, which is one of the catchy area where you will get question in both in 1 and 2 exam. So hepatorenal syndrome, you should mark up all the criteria of hepatorenal syndrome and your management. So patient with advanced cirrhosis, approximately one-third patient develop hepatorenal syndrome. Let's see. Uh, the cirrhosis ascites high risk for hepatorenal syndrome. However, incidence is approximately 18% in the first year and increases 40% on the 5 year. So within 5 years, there is a 40% or one-third. And then UK unit for alcohol, single UK unit alcohol containing approximately 2024. It is half of that. It is 10 to 12 gram of ethanol. And chronic consumption exceeding 40 gram per day in men, 10 to 20 gram per day in women, associated increased risk of alcohol related liver injury. Then your alcohol related liver disease may be complicated by Wernicke encephalopathy. Yes. Yes. Hello. Wait a minute. Hello. Okay. Then next statement. Uh, oh, sorry. Metabolism, ethanol promote lipid accumulation of the hepatocyte. Uh, yes, it increase the fatty liver and tumor necrosis factor, reduces hepatorenal syndrome. No, there is no relation. Now coming to hepatorenal syndrome. Hepatorenal syndrome is uh, it's a functional renal failure, potentially reversible renal failure when the liver is replaced or liver is improved. The hepatorenal syndrome also improve. The primary pathophysiology is severe renal vasoconstriction secondary to systemic and splenic vasodilatation, which causes the renal failure. So, portal hypertension, splenic vasodilatation, reduced effective and arterial blood volume, activation of the RAS, and causing renal vasoconstriction. Type of hepatorenal syndrome. Type of hepatorenal syndrome. It is type 1 and type 2. Now is type 1 hepatorenal syndrome termed as a hepatorenal syndrome with AKI. And type 2 hepatorenal syndrome is and type 1 and type 2. Type 1 hepatorenal syndrome is hepatorenal syndrome with AKI, and type 2 hepatorenal syndrome is a chronic when there is a refractory acidosis. Diagnostic criteria with following not diagnostic criteria is significant proteinuria, hematuria suggests interstitial renal disease, exclude hepatorenal syndrome. And the diagnostic criteria for hepatorenal syndrome should have cirrhosis, increased serum creatinine, no improvement after diuretics withdrawal or albumin expansion. Uh, then absence of shock is the diagnostic criteria. Regarding the principle as assumption and limitation of esophageal Doppler monitoring assess following statement. The technique is based on measurement of the blood flow velocity using Doppler frequency. Blood flow velocity is the descending thoracic aorta can be calculated directly by aortic cross-sectional area is known. The method assumes that approximately 70% of total cardiac output pass through the descending aorta. Esophageal Doppler probe must be removed within 7 days of insertion. Measurement remain reliable patient with active epidural block. So esophageal Doppler monitoring rely the Doppler effect and where the frequency shift of the reflection ultrasound wave for moving red blood cell is proportional to blood flow velocity within the descending aorta. Mm. The device directly measures blood flow velocity, not cross-sectional area. Stroke volume is estimated by the combining of the velocity time integration. Stroke distance is assumption aortic cross-sectional area divided in derived from normogram based on the patient age, height, weight rather than the directly measure the anatomy. Fundamental assumption of the esophageal Doppler monitoring is approximately 70% cardiac output is directly caudal through the descending aorta and remaining 30% supply head, upper limb and coronary circulation. Esophageal Doppler probe has been possibly used period exceeding up to 10 to 14 days without significant complication. Provide appropriate position and monitoring are maintained. Presence of functional epidural may reduce the accuracy of the esophageal Doppler measurement due to sympathetic block, vasodilatation, altered systemic vascular resistance, which can disrupt the assumption of underpinning the technique. With regard of liver transplant, perform acute liver failure, evaluate following statement. Majority of the post-transplant mortality in ALF occur in the first 3 months following surgery. Recipient with ABO identification donor graft have been higher mortality risks than those receiving non-identical graft. Approximately one-fifth of all liver transplants are carried out for acute liver failure. Early postoperative graft transfer dysfunction is poorly tolerated in ALF recipients. Beyond the first postoperative year, long-term survival in acute liver failure transplant recipient exceed the patient transplanted for chronic liver disease. Now, nowadays liver transplant again coming in your part one MCQ. So you have to thoroughly read the liver transplantation and the criteria for brain death, cadaveric donor. The following liver transplantation of the ALF, mortality is highest in early postoperative period. Most deaths occur within 3 months and survival rate around 70 to 80% first year and 70 and around 70% is 5 year. Usually is recommended for 5 year survival. Then next statement, increase post-transplant mortality associated advanced recipient age, marginal, what was the option? ABO identical graft have higher mortality risks to receiving non-identical graft. No. The increased post-transplant mortality associated advanced recipient age, marginal graft, split and partial graft, and the ABO incompatibility. ABO identical graft are associated with improved outcome, not increased risks. Only small portion of the liver transplant are performed in acute liver failure, reflecting relative rarity condition compared with chronic renal failure. Usually, the chronic renal failure patient are getting liver transplant more and more than the acute renal failure. And early postoperative impaired graft function is poor tolerant and predisposed to intracranial hypertension and sepsis, yes. And also, although the early mortality following transplant is higher than the chronic liver disease, long-term survival beyond the first postoperative year is superior, likely due to fewer comorbidity, absence of chronic disease occurrence. Regarding paracetamol, acetaminophen toxicity management as is following statement. Paracetamol poisoning, one of the key area in the part one question. So toxic metabolite N-acetyl P-benzoquinol imine is the generated primarily by hepatic glucuronidation of the paracetamol. Treatment is indicated when plasma paracetamol concentration are more than 100 milligram at 4 hour, 15 milligram at 15 hour following injection. Paracetamol treatment normograph remain valid in case of suggested it is supratherapeutic injection. Initial loading dose of intravenous N-acetylcysteine is 1.150 milligram per kg administered over 1 hour, and previously hypersensitivity reaction constituted absolute contraindication of NAC administration. So hypersensitivity reaction, NAC, rash, bronchospasm are not contraindicated, and antidotal benefit of NAC is always have to take. And then the initial loading dose is 150 milligram per kg over 1 hour, followed by 50 milligram per kg for 4 hours, and then 100 milligram per kg over 16 hours. And completing standard 21 regimen, ongoing treatment depend upon the biochemical response. Paracetamol treatment normogram, yes, this is also true that Romchak Matthew normogram is not reliable case of suggest staggered in ingestion, repeated supratherapeutic dosing, or unknown ingestion time. In such scenario, treatment design based on clinical assessment, biochemical marker, and rather than the normogram. So normogram for acute uh, ingestion, but if there is a repeated supratherapeutic dosing or unknown ingestion time, then it is not valid. Then acute single time ingestion plasma parasitic. Okay, question to the parent. The toxic metabolite of paracetamol primary via hepatic glucuronidation of paracetamol. It is paracetamol predominantly metabolized in the liver via glucuronidation and sulfation to non-toxic conjugation. Small fraction undergo oxidation by cytochrome P450 system and form NAPQI. So NAPQI is not via glucuronidation. It is via oxidation by cytochrome 450. The highly reactive and hepatotoxic metabolite, the overdose happen when the depletion of the glutathione level in the liver. So when there is a glutathione deficiency in the liver, more and more paracetamol are going to metabolize in oxidation and produce NAPQ, which causes the mainly leading to hepatocellular necrosis. So I'm keeping here uh, Fatma. Hello, Fatma.
Yes, sir.
I'm keeping here because there's a sick patient. The repeated call is coming. So I will take another day the rest of the question.
Sure, sir.
Yeah.
Thank you.
Thank you, guys. So we'll meet with the rest of the question. Meanwhile, if you have not given the exam, please go through and give the exam, and we'll meet soon.